I'd like to thank the organizing committee for the opportunity to give this invited lecture on how far have we used FODMAPS, a practical dietary guide for patients with irritable bowel syndrome. We know that food is an important factor for our patients with IBS, where a majority report food as a major trigger for their symptoms, and more than 60% of these patients modify their diet to control symptoms. Therefore, dietary therapy provides an opportunity for self-empowerment. As highlighted in the 2021 review by Professor Bill Shea, dietary management is now recognized as a key component of integrated care for irritable bowel syndrome alongside psychotherapy as well as medical management. This work meta-analysis or forest plot published in 2022 in Gut of 13 randomized controlled trials shows the efficacy of diet therapies in achieving global IBS symptom improvement. You can see here that the low FODMAP diet ranks first compared to habitual diet and was superior to all other dietary interventions. There is also the emergence of the Mediterranean diet and a low carbohydrate diet that have shown preliminary benefit but require further investigation. I'm also pleased to see that Korea is one of the few countries that now include the low FODMAP diet as a first-line therapy for treatment of IBS. And I can only see that this region will have increased uptake of dietary therapies. For my talk today, I'm going to expand on how we can better utilize the three-phase FODMAP diet for management of IBS, where we know that the diet now is not just purely restriction of FODMAPs, but has evolved to a three-phase FODMAP diet with reintroduction and personalization. Phases 2 and 3 of the diet have really emerged because we know that a low FODMAP diet is not a long-term solution because of concerns due to nutritional risks, so inadequate calcium, iron, B1 and fiber. There have been reports how the low FODMAP diet may negatively impact on putatively beneficial gut bacteria, but also that a low FODMAP diet can reduce diet quality and variety during the restrictive phase. And so the three phases are outlined in this figure here, where you have the blue line showing FODMAP intake, where by restricting this intake, we're really reducing symptoms, which is depicted as the red line. And then this is followed by a reintroduction period where FODMAP intake will increase and potentially symptoms are induced. So we're really looking at identifying triggers and dose response for individual FODMAPs and then liberalizing for the longer term. However, before implementing a FODMAP diet, it is important to assess the suitability of a patient. So you have here an IBS patient with food-related GI symptoms, and we're really looking at the frequency or severity of symptoms, whether this is mild, the potential for disordered eating, and their ability to make dietary changes. There will be a proportion of patients who may not be appropriate for implementing a FODMAP diet. These include patients who are currently asymptomatic or who have multiple existing restrictive diets such as gluten-free, soy-free, egg-free, or if they've got a history of disordered eating or an active eating disorder. In addition, this will help guide the level of FODMAP restriction. So if they've got mild symptoms, they potentially may not need a comprehensive, strict low FODMAP diet, but also to understand the role of other dietary triggers such as spicy foods or high-fat foods, or whether there are other nutritional issues present, such as if patients are only eating one meal a day and therefore they may be at risk of inadequate nutrients such as fiber. So, expanding on phase one or the low FODMAP diet, this is really to be undertaken for anywhere between 2 to 8 weeks. The goal of this FODMAP restriction phase is not a strict elimination diet, but really to reduce the level of FODMAP intake below the tolerance threshold by swapping foods that are high in FODMAPs with lower FODMAP alternatives. However, the first thing that is key to the education of a low FODMAP diet is educating patients about what happens in the gut with irritable bowel syndrome, so what physiological changes occur, and mechanisms for symptom induction is a key first step. This elegant MRI study provides a good example as it demonstrates how visceral hypersensitivity is the key mechanism for symptom induction in IBS. So you can see here the patients with IBS, there is an increase in small bowel water content in response to fructose and inulin, with a corresponding increase in colonic gas volume and accompanying increase in symptom severity during this challenge. However, in in healthy controls, similar mechanisms occur. However, healthy volunteers don't experience the same level of symptom as those experienced by patients with IBS. This really highlights that not everybody gets symptoms when eating onions, wheat, legumes, or excess fructose. When we look at lists of foods that are high in FODMAPs versus low in FODMAPs to be swapped or to be used as alternatives, you can see that those that are high in FODMAPs, there are a range of FODMAPs that are present across the different food groups. And therefore, it's really important to therefore have a broader reduction in FODMAP intake with replacement of low FODMAP food alternatives to really successfully implement phase one of the study. I'm actually going to take it one step further by adapting these FODMAP lists to what is often found in the South Korean diet. So if you look here in the vegetables section, foods such as cauliflower, mushrooms, snow peas, celery, and corn, depending on the amount, are classed as high FODMAP foods, and these can be replaced by green onion, bean sprouts, lettuce, seaweed, etc. You also have nashi pear, which is really, really high in fructose sorbitol, excess fructose and sorbitol, but also pear juice, and any marinated meats in honey or pear juice, as well as silken tofu being high in galacto-oligosaccharides. But when you look at those additional foods that are often used in the Korean diet, butter, for example, does not contain lactose, and sesame seeds is a low FODMAP seed alternative. When you look at breads and cereal products, you can use things like, sweet potato noodles, soba noodles, tteokbokki, rice, and plain sweet biscuits as a replacement for instant wheat noodles, wheat bread, or pizza bases. But I find that there are a lot of high FODMAP ingredients being added to food products that are processed, such as oligofructose being a common high FODMAP ingredient, high fructose corn syrup, FOS, and inulin. And so really teaching patients on label reading is important for this phase. In addition, I've also taken some of the very common high FODMAP South Korean dishes. You can see here you have jjajangmyeon, which contains garlic, onion, and wheat. You have budae-jjigae, which also contains gos from baked beans, apart from garlic, onion, and wheat. And also japchae, which the sweet potato noodle is actually low FODMAP, but garlic, onion, and mannitol are your high FODMAP, your FODMAPs in this dish. There are also some Korean dishes that are naturally lower in FODMAPs. So you've got kimbap here on the left, but also bulgogi can easily be adapted to be low FODMAP. Your Korean barbecue often contains ingredients that are low FODMAP, including the grilled meats and the green onion, but also your sam. And then your Korean fried chicken, which mainly just contains a little bit of dusted plain flour, is low FODMAP. Important for the success of the diet in phase one is to equip patients with resources to follow the diet. And the Monash FODMAP app provides a long list of foods that are low, moderate, or high in FODMAPs using a traffic light system, and also a range of 80 delicious recipes. But we're really needing these recipes to be adapted for South Korean cuisine. We have also tested a few low FODMAP food products for certification, which you can see here. What about troubleshooting the diet where a lot of foods in the South Korean diet have an unknown FODMAP content? Well, the first approach is really to restrict only foods that are known to have high FODMAP, and so garlic, onion, wheat products, and certain fruits, vegetables, but allow consumption of food with unknown FODMAPs, for example, the different sauces or condiments. The second approach is to restrict both foods with known high and unknown FODMAPs, which is more restrictive, achieve symptom control, and then reintroduce these foods systematically to test tolerance. But I think that broad principles of the FODMAP diet still apply. For example, animal protein that don't contain any marinade or sauces and oils have very little carbohydrates, so naturally they're low FODMAP. For example, your perilla oil would be assumed to be low FODMAP. The other thing to note is that fermentation and pickling also lowers FODMAP content. So, for example, kimchi often will have a lowered FODMAP content. The other approach is to use less restrictive versions of a low FODMAP diet, such as a FODMAP gentle diet, which is initially coined by our team in 2019, or a FODMAP simple approach, as illustrated here. This is a study conducted in the US, published this year, using a FODMAP simple approach, which only restricts fructans and GOS, so wheat, garlic, onion, high fructan vegetables, and high galacto-oligosaccharide legumes. You can see here in terms of the proportion of patients that achieved the FDA endpoint for 30% reduction in pain was similar in those following a FODMAP simple compared to those that followed a traditional low FODMAP diet. And similar findings for symptom relief achieved on both approaches in this study. To really hone in the concept of FODMAP gentle, again, adapting this to the South Korean culture is targeting FODMAPs that are most typically consumed, or really only focusing on reducing foods with highest FODMAP content. This is a dietary assessment of a large number of Korean IBS patients on what the habitual diet contains in terms of FODMAPs. And as you can see here, fructans and lactose constituted the biggest FODMAP proportion in the habitual diet of South Koreans. So the FODMAP gentle approach could really target a reduction in lactose and fructans as the first step, and then refinement of the diet may focus on other FODMAPs such as excess fructose or sorbitol. Moving on to the FODMAP reintroduction, phase two. This will take a longer period of 8 to 12 weeks, where really we want to be assessing whether patients have had adequate symptom improvement following the first phase of the restrictive diet. If they have had no response to the diet, however, the important thing is to evaluate their adherence, and if adherence is adequate, return them to their habitual diet and utilize alternatives for IBS symptom management. If they have achieved adequate symptom improvement, the next step is really to reintroduce all restricted FODMAP subgroups in a systematic manner. This really utilizes a patient-centered approach, so working collaboratively with the patient to identify specific triggers and dose tolerance, and that the order of reintroduction is really based on what the patient misses in their diet, but also any nutritional needs. So, for example, if the patient is constipated, oftentimes we do tend to reintroduce urosmotically active FODMAPs to try and improve or achieve laxation. As part of the process of reintroduction, we ask patients to continue on a low FODMAP diet as a clean base, and that we re-challenge individual FODMAPs over 2 to 3 days. And so you can see here in this graph a stepwise approach where one FODMAP subgroup is a challenge at a time, and we're increasing the dose to usual intake as tolerated. Once the patient has completed one FODMAP subgroup, we will take a break, and that we ask patients to monitor their symptoms following a challenge. If they have had symptoms occurring after day 1 or 2 of the flare of the challenge, then we usually suggest stopping the challenge and moving on to the next FODMAP subgroup. When we look at examples of what foods to be re-challenged for each FODMAP, for example, with excess fructose, you can utilize honey. And these amounts that are listed here are often your starting quantities, but we really want them to be increasing the dose until they reach what they typically consume. Adapting this again to the Korean setting, I'd be suggesting the use of wheat noodles for the Fractan challenge, and also silken tofu for the GOS challenge. Patients can also customize their own challenges. For example, they may wish to reintroduce spicy foods that don't contain any other FODMAPs. Moving on to phase 3, which is the FODMAP personalization phase. This is really a tailored plan containing some safe to consume FODMAPs and avoiding those that trigger IBS symptoms for the longer term. So really their long-term diet. And the goal is to find a balance between acceptable symptom control, variety, and good quality of life. And there may be periods where, given IBS is a chronic condition, patients will require a short-term implementation of a low FODMAP diet again, where symptoms are exacerbated or recur. But when we look at the outcomes of each FODMAP challenge, we really want to be classifying them to either well-tolerated, those that have some symptoms, or those that produce severe symptoms. For those that are well-tolerated, we ask that they reintroduce the tolerated FODMAPs back into the diet. With those that produce some symptoms, reintroduce when able, or repeat the challenges with smaller amounts, and if tolerated, including these on a less occasional basis. But those with severe symptoms, to avoid these challenges for now and to retrial the challenge in the future of approximately 6 to 12 months. And we do find that tolerance will vary over time, and that patients have a chance of tolerating foods that they have previously not tolerated. Our group has also recently published long-term data of patients that were initially educated on a low FODMAP diet in our center. This study included 74 patients with IBS who followed a low FODMAP diet, and we found that initially a large proportion of these patients documented good symptom response, but in the 7-year follow-up period, a large proportion of them maintained this satisfactory relief of symptoms. In the patients that also tended to restrict their FODMAP, this constituted a large proportion of patients, whereas 11% of them followed no restriction, and 4% of them were unsure. Those that continued a strict low FODMAP diet had the lowest food-related quality of life compared to those who had returned to their habitual diet or had partial restriction of the FODMAP diet. So this really highlights that long-term symptom control with a FODMAP diet, regardless of whether they've restricted or not, it can be maintained over a long period. Finally, I just want to touch on the importance of a GI dietitian for the success of a FODMAP diet. Here you have a study published in 2020, including 80 IBS patients, where a third of them consulted a dietitian. And if you look at the proportion of patients that followed the 3 phases of the FODMAP diet successfully, people who saw a dietitian were more likely to follow each of the 3 phases appropriately compared to those who saw a GP or a gastroenterologist. And so this really highlights the importance of guidance of a restrictive diet in mitigating risks, but also achieving good symptom control of the diet. And so we as a team at Monash FODMAP is very committed to increasing accessibility of FODMAP trained dietitians, and this includes South Korea, where you may be familiar with our FODMAP dietitian training course. This is a self-paced learning online course that can be accessed on our website, but we also run a symposium called Gastro Diet, the last one being run out of Monash University, Malaysia, and we've had so far 2 Korean dietitians attend these training sessions. Really, were you wanting more dietitians from South Korea to attend the next Gastro Diet, which will be held again in Malaysia in September next year. So to summarize, I'm not going to go through all of this, but the FODMAP diet has shown good long-term efficacy for IBS symptom control and can be adapted to your South Korean context. But really, we need to be looking at the utility of simplified FODMAP versions, but also the need to train more dietitians in South Korea to adopt this diet. And as acknowledgements, I'd like to thank the Monash FODMAP team that has enabled this lecture and the expansion of the diet to be possible. Thank you.